and according to the general situation and the circumstance that surrounding our country, especially in Yemen, and the general situation these days. So, according to this, we are planning to do a good plan for management of penetrating brain injury. Planning to do a good plan for management of penetrating brain injury. So we'll start. Definition of penetrating brain injury is a traumatic brain injury caused by low velocity sharp objects, such as a knife or high velocity projectile, such as shell fragments or bullets. Blast injury is also considered to be traumatic brain injury, but as a consequence of the donation of complex explosion, with or without penetrating brain injury. According to that, the penetrating brain injury, as we can see, is considered to be a major health problem, and many deaths can occur due to that. And according to that, the pattern of penetrating brain injury in civilian and military have been classified up to the following: to perforation, all penetration, or tangential. This is the classification of penetrating brain injury. This is some pictures of our research that has been done. This is one case that we are working this case during that period of. And this is an example of the perforation brain injury. Perforation, it means that the bullet or the sharp nail or the fragment has an entrance and an extents pathway during its pathway. And we can see in this picture, this is the entrance and this is the extents. With the X-ray is more clear. We can see with the CT scan, it is more obvious here with the much traumatic injury to the brain. Another example we can see in this next case, this is also a perforation type penetrating brain injury. We can see the hematoma inside the brain and the fragment is still inside the brain. This is an example of the case that also had been working during that time. This is another case. This is a hard part. We can see this part. And this is diagram is showing for us the crâniocerebral gunshot injury and how we can manage such a case. This depending on the general picture of the patient when he coming to the ward, when he coming to the ER, and we are evaluating his condition. The most thing that you are using in evaluation of such a patient is the Glasgow Coma score and the CT scan finding that we can see during that time. If the Glasgow Coma score is Glasgow Coma score 3, it's mostly is the Glasgow Coma score less than 5. Most of the case they are managed as non-surgical, and most of them they admitted to the ICU, and good resuscitation. If improved, patient can be shifted to surgical or can be continuous to non-surgical. If the Glasgow Coma score more than 5, and there is with the brain CT scan, there is space occupying lesion, hematoma, such as subdural hematoma or intraparenchymal hematoma, surgery is the best option for that patient to survive him. If there is no hematoma and Glasgow Coma score up to 8, it is if there is extensive brain injury, no surgery we need. If there is limited brain injury, surgery is the best. If the Glasgow Coma score more than 8, is sometimes they prefer to do surgical. I give this picture. This is because worldwide and since a long time, there was a conflict about the management of penetrating brain injury. And multiple changes had been occurred since the World War I. We can see during the World War I and the World War II and during the Korean and Vietnam injury, we can see they were all of them, the best management for that patient, all of them shifting to aggressive debridement for that injury. If there is a deep sharp nail or there is extensive brain injury, they was doing at that time extensive debridement and also removal of all fragments and sharp nail. But they found later on there is a lot of cases and a lot of morbidity and mortality had been occurred. So they think a lot and they have been shifting to another era. You can see during Israeli-Lebanon war, during Israeli-Lebanon war and Iran-Iraq war, most of them they're shifting to conservative management. even if there is injury to the brain, and if there is small injury, only they was just do minor debridement with closure of the skin. Also, during that time, they saw a lot of complication for that cases, and they saw a lot of morbidity later on due to the complication of that case. So during Afghanistan war and during operation of Iraq, they shifted to less aggressive and with more conservative management. They saw that the fragment, you have to do debridement only for the close fragmented at that time, dura closure, and if there is an accessible hematoma, you have to evacuate the accessible hematoma, and the deep fragment or the sharpening that they are deep, you have to leave it in space and close and follow up the patient. So now we'll start abstract. Our objective for this research is characteristic and pattern of patient with penetrating brain injury, and to analyze the relationship between admission, Glasgow Coma care, and outcome, and at the same time modalities of management. This study was retrospective cases, serious descriptive study was carried out in the Department of Neurosurgery at Athora Hospital, as I said, from December 2017 up to December 2018. These cases were studied of penetrating brain injury by bullet or sharp nail, depending on the admission, Glasgow Coma care, and CT scan during the admission patient to the ER. Location of the injury, even what is the site of the injury, frontal, temporal, parietal, or posterior. We revealed the outcome of that cases that were managed conservatively, and of that case who are operated, and complications related to the penetrating brain injury. The aims of our study at that time, it was to address factors affecting the severity and outcome in patients with penetrating brain injury. And also at the same time to make a clean issue on management plan of patients with penetrating brain injury, depending on the admission status and the CT scan finding. You have to build a good plan according to the status of the patient during admission to the ER. The last aim of our goals is to set a protocol regarding management of penetrating brain injury in our department. The result that we have seen in our research, we can see most of the case, the pump explosion was mostly observed in more than 62%, followed by gunshot in 29%, and then stab wound in only 8%. 53 of the patients present with penetrating type injury, as I said, penetrating type injury is with entrance only without extents. In relation to perforation, it was only 29% of that, and the others it was only tangential injury, in which just only touching the scalp and the skull. The injury was in the frontal lobe, mostly the case that we are faced, it was the site of the injury was mostly in the frontal lobe in 70% of the patient, followed by the parietal, then temporal. As also we observed, 55% of patients has good Glasgow Coma scale at admission, and with 35 had Glasgow Coma score less than 8. Those also we can see, those who present with, this is an important point, we can see those patients who present with subdural hematoma at time of admission by CT scan with mass effect and midline shift, and the tract, if the tract is transferring through multilobar, had bad outcome in relation to the others. Also of that result, we see that most common complication in our study used to be infection in 7 patients, also CCF leakage was in 5 patients, early convulsion in 5 patients, and hydrocephalus in only 2 patients. There is other complication in 4 patients. Mortality in our series, it was 5 patients, about 9.8%, with 4 had Glasgow Coma scale grade less than 7. The Glasgow Coma score was low during the admission, and 1 patient with Glasgow Coma scale grade less than 7. This patient is related to he had an infection post-operative, and also a lot of complication. EVD was done for him, but he has been staying on the ICU for more than 2 months. Then he had been expired. No relation between retained. We can see also in our study, this is an important point we can see, because most of argument during the war, all the time, it was about the relation of infection to the fragment. And we see in our study, there was no any relation between retained fragments, if there is an fragment retained inside the brain, and with and those without fragment in relation to infection. There was no any difference between these. And also we observed those with pump explosion and with very low Glasgow Coma scale, and treated accordingly, improved to self-dependence, inversely those with gunshot. that we have pump explosion. If the patient comes to you with penetrating brain injury or perforating brain injury with pump explosion, even with the Glasgow Coma score is low, you have to give him the best. Most of them or less of them can be improved up to the point they can depend on
Muhammad, you have
themselves.
1 minute, please.
Okay. This is some pictures. I can see this is the diagram to show the perforation and the others. We can see the diagram. This is the perforation as seen in 50%. Also, this is a table seeing the percentage of the case that we are observed in relation to Glasgow Coma score. And also, this is related to the case that had been treated, the conservative management. You can see about only few cases have been treated conservatively. We have only 12 cases, and the others was operated. Also, this diagram showing the mechanism of injury in relation to the Glasgow Coma score. We see the explosion, most of them who have with explosion, they have Glasgow Coma score better in relation to those with gunshot. Relation of CT finding to Glasgow outcome score, also this diagram shown. Literature review, we have compared between our study and other study. The most comparing studies that, and study that done in Turkey between 1992 and also 28, about 42 patients have been studied at that time. We see there is a close relation between our study and their study. Most trauma, it was on the frontal lobe. And also the most common complication in this study was infection at that time. The mortality state of this study it was too much at that time, more than 20%. And also we can see most of them, they are admitted with low Glasgow Coma score. And mostly of that cases that had been admitted in this study, it was relation to operated at that time.
To the conclusion, Muhammad, please.
Okay, thank you. The most limitation point in our study, it was a retrospective study, short time follow-up of the patient. A case that operated outside cannot be evaluated and not involved in this study. Conclusion, penetrating brain injury encountered in young male patient with increasing frequency in childhood. Pump explosion with fragments or sharp nail is the most common mechanism of penetrating brain injury. Frontal lobes followed by the parietal and then temporal are the major location to be injured in penetrating brain injury. Extensive operations associated with more operative time and more manipulation and more damage to normal brain tissue with more complication, infection and seizure as compared with minor operation and conservative group. Also, this debridement does not prevent infection. Low Glasgow Coma scale at arrival and CT scan finding of subdural hematoma or intraventricular hemorrhage and associated chest, abdominal and spinal injury are all factor affected outcome and bad prognosis. The recommendation in our study, it was penetrating brain injury need patents and meticulous planning. Indication for surgery must be clear and if possible, conservative management should be preferred. Surgical exploration, if needed, should be done by the expert. This is an important point because some cases was done by the juniors and that the result was bad. Conservative treated patient should be evaluated in well-equipped neurosurgical ICU and if needed, intracranial abrasion monitoring. It is not available in our country. A management protocol for penetrating brain injury should be created and published all over the country. Our surgical care of patients with traumatic brain injury caused by penetrating injury is not optimal because rapid transportation to the hospital and urgent surgical intervention. This is a major problem for us. Most of patients coming after 10 hours of the trauma. More and multi-center study of penetrating brain injury, including the military and civilian patients all over the country. Thank you very much.
Thank you, Dr. Muhammad. Thank you.